We have a lot of folks here from a lot of different programs. We have attending physicians, program directors, we have residents, students, nurses, we have APPs. We have just a really incredible amount of expertise in this room, and I'm so honored to be asked to sort of help moderate this. And obviously a huge thank to Mike Palacci and to everyone who's volunteering to do this, because what we're talking about today is really important. And it's really not just about the law, right? It's about the medicine mostly. And so though you will hear different viewpoints from each side, we picked this case because we thought, well, there are arguments on both sides. It's not esoteric, but it's not obvious either. And because of that, it feels like this case has really good teaching potential. This is a case that literally all of us will see many times in the course of our careers. And there's not only a question about diagnosis and failure to diagnose, but there's also a question about the timeliness of the diagnosis, because this is one of those really true urologic emergencies. And we do have an opportunity to change an outcome, to change the patient's life, but then also, even focusing back on ourselves, to change our own trajectory in our careers, in the sense that no one wants to go through a medical legal action, because the average time is almost 4 years, about 45 months during the course of that. And there's all kinds of things that we deal with during that, maybe increased alcohol or substance use, problems with sleep, marital problems, all those sort of things play into when we go through a legal action. So most of this is for the patient safety aspect, of course, but we have to think about ourselves also with that too. And sometimes even just the very act of documentation, I believe, can make patients safer. Sometimes the act of using that medical decision-making section as what I call a hard stop, thinking to ourselves, did what I write down make sense as an argument, right? An argument why I think it's safe to send this patient home, or why I think it's appropriate to start this patient on certain medications or to admit this patient, right? Does my story, as reflected in the documentation, make sense? So what I wanted to do is first tell you not only the story of us, but tell you the story about the patient. And I'm going to have this actual case, which was a true case, and this was the actual documentation of the case. So nothing's been changed for like HIPAA reasons. Obviously, there's no patient identifiers here, but we're going to play this thing out with people who were not actually involved in this actual case. So they will be having their own original arguments, their own original defense, all those kind of things with this. So the problem we have, of course, in the emergency department is that we're not only thinking about patient safety, but we're trying to balance what I call the 3 S's, which are safety and speed, right? And satisfaction. So that's one of the big problems with any medical legal action, is like you think to yourself, is like, here is this physician, Dr. Shure, right, will be our volunteer physician, and he'll be sitting up here and he'll be telling you about his care of this patient, but what he's not telling you is that he's probably caring for 10 other patients at the same time. And we all know that well, obviously working in the emergency department. One other thing that's really important, and we have a lot of nurses and other folks that are caring for patients as part of this healthcare team, is that folks that actually document things in the chart that are not the physician or the PA or NP, right? That part is absolutely as important, and so frequently, and I'm sure when we have a question and answer session later with our plaintiff and defense attorneys, we'll probably tell you that one of those big things is when something is documented by the nurse and that's not acknowledged by the physician. In fact, sometimes the triage will have one chief complaint and the diagnosis will be completely different, and that chief complaint of the patient was never actually even reflected in that documentation. So what is malpractice? Very briefly, I'm going to go through this, and then we're going to get into our trial pretty quickly here. So malpractice is really 4 things that you need to prove malpractice. The first, I should say, the first and third thing are pretty obvious, right? That we have a duty. We're wearing a white coat and the patient is, shivering in the thin hospital gown. That's pretty obvious, right? And that there was harm, and that's usually not too difficult to prove either, right? The patient's horizontal and room temperature. We got that. But the number 2 and number 4 are the ones where really things come down to. And number 2 is the standard of care, and I think we all know the definition of that. But the standard of care is also sort of followed by what's called causation of the proximate cause, and that's did the actions that I took while I saw this patient, did those actually cause harm? Or maybe the actions that I didn't take, could they have resulted in saving this patient? Did the actions that I took result in whatever finally happened to the patient. And we're going to be talking about some of those things a little bit here later. Obviously, we always want to sort of defend ourselves on a standards defense. It's better to say I did good care instead of I did bad care, but the patient would have died anyway. That's probably not the defense that you want to use, Carl. You agree with that one? Yeah. Okay. So here's my definition of malpractice, because interestingly, malpractice is not a misdiagnosis, or it's not failure to make a diagnosis, because we don't want to diagnose every single thing and have a zero acceptable miss rate, right? And in fact, ASAP, American College of Emergency Physicians, actually says in the 2018 chest pain guidelines that we do have a 1 or 2% acceptable miss rate for acute coronary syndrome, and specifically says in that practice document that if we try to get lower than that, we are going to cause harm because of false positive testing and extraneous testing and all the other things that happen when we overwork up patients, right? So again, that balance of the 3 S's, but also the balance between trying not to miss a serious diagnosis, right? And the risk of over-testing and potentially causing harm by that. So here's what I think is malpractice, is poor data gathering and poor medical decision-making. And I think you'll see in this chart that both of those were good, but the question is, can we move from standard of care to excellence in care? In a trial, we only need to prove standard of care, but I think what we are all striving for in our careers, of course, and the way that we want our own family members treated is for excellence in care, of course. Here's a couple good news things. One is that emergency medicine is not the highest sued specialty. And so this study by Jenna, it's a little bit higher than average, right? But, you know, not incredibly higher than average. We see that urology is a little bit higher on there. Sorry about that, Fabrice. But here's the thing, is that most legal cases, and just little statistics and data for us beforehand, failure to diagnose is the most common thing. A good bedside manner, and based on a lot of studies, Hickson and other ones, can actually help avoid a lawsuit in the first place. The median time to filing is 15 months, but the average time to completion is almost 4 years when it goes to trial. So those aren't cases that are dropped. But here's a couple other things that might not surprise you. 75% emergency physicians are sued, but of those, 71% are dropped. And most likely, the average emergency physician will never see the inside of a courtroom. So to me, that feels like good news. If you do see the inside of a courtroom, about 85 to 90% of the time, that goes for the defense. But as one of the past presidents of ASAP has said, in a medical malpractice action, there are 2 losers. There's 1 loser and a bigger loser, right? So no one wins when you go through 45 months of this sort of pain. So what I'm going to do is I'm going to tell you just briefly about this patient, because everything starts with a story. And then I'm going to tell you what happened to this patient. Before I do that, I just want to give you, and we'll have that up on the thing here later, but this is going to be actually looked at as a real trial. We're going to actually have a jury. We're going to sort of pick the jury. We'll do that pretty quickly in just a little bit here. But we have a plaintiff attorney, we have a defense attorney, we have 2 experts for the plaintiff who are a urologist as well as an emergency medicine physician. We have one expert only, sorry, Carl, you only get 1 expert for the defense, which is an emergency medicine expert. And then the other one for the defense is actually the physician who saw the patient, who is not actually saw the patient, but that's Bryan, who is the volunteer physician. And so we're going to go through this. We'll have a break in the middle. And then at the very end, we're going to have our jury, which will be 8-person jury, so I'd like to try to have maybe 1 person from each different program. We want to have a nurse and a PA or NP, a lot of assortments, but that this will be a true jury of our peers, right? When you think about it, it won't be, a person who, does other types of jobs, right? It'll be actually healthcare people. There'll be a true jury of our peers that will be deciding this. And in the end, it's going to be the plaintiff's responsibility to prove that there is malpractice, because that's one thing that sort of helps the defense person out a little bit. So let me first tell you about this patient. This patient's name is Linda Baker, and she lives in a large city in the Northeast. She's 67 years old. She is active in philanthropic organizations, and she and her husband had worked long careers and were now enjoying their retirements. They have children, they have grandchildren that they enjoy spending time with. Linda has had some medical issues. She's been treated for breast cancer, ovarian cancer, and also brain cancer. But she's independent, and she lives with her husband, and she's asymptomatic for those things. So on a cool fall day in October, she is awoken suddenly with severe right flank pain. You've seen this patient before. She tries to reposition herself and fall back to sleep, but the pain persists. She's frustrated because it is Yom Kippur and she doesn't want her plans to be interrupted. She has been fasting since sunset the previous evening. Soon it becomes clear the pain is not going to resolve it on its own. She does have a history of kidney stones. This feels similar. Her husband drives her to a nearby emergency department, hopefully thinking that her pain will be controlled. So this is the actual documentation. This is the first half of the documentation. And I've sort of highlighted in purple some of the things that you want to look at a little bit more closely. And I also passed out, I think maybe there weren't quite enough copies, but a lot of you will have that, and you can sort of refer to that, back to that during the course of things. So most of the time in a medical malpractice action, the foundation that people are arguing on is based on the chart. And oftentimes things are, later looked at and you don't really know because they don't remember this patient, right? In this situation, our physician does remember this patient because her adverse outcome happened so quickly thereafter and they were informed of it. We can assume it that way. But here's the actual documentation from the nurse. It says, patient received in stretcher with right flank pain since 6 a.m. Sudden onset, radiates to right lower abdomen, denies chest pain or shortness of breath, denies fever, but complains of chills. But it says, I always have chills. It's been cold. She denies dysuria. She has right CVA tenderness. The physician documents, I'm not going to read the entire thing to you, don't worry. 67-year-old woman, past history, as we talked about, and she has right flank pain since 6 a.m., started lower abdomen, radiated to the right side, went to the right flank. She tried some gas X, had some 3 episodes of vomiting, and they document, again, no fever, no diarrhea, constipation, dysuria, blood in the urine. She has a whole bunch of allergies, as you can see, as well as the ones that I highlighted in purple, allergies to antibiotics. And she has an exam that, not surprisingly, shows that she has some pain in the right lower quadrant and right costovertebral angle tenderness. So thinking to yourself, it's like, this seems pretty straightforward. Doesn't really seem like this is going to be one that's going to trip us up, right, medical legally or even patient safety wise. And so what happens is the patient gets some labs, and we can have an argument whether you need labs or not, but they did the labs. So got a white blood cell count, which is normal. The creatinine level is 1.7, not really a mention made if that's like higher than usual or not, but maybe that doesn't really even matter that much. And a urinalysis that shows positive for nitrate, leukocyte esterase, blood, and a CT scan shows a 3 millimeter obstructing stone. The patient feels better. So if you look back at the times, 11:37 a.m., the physician, and then about 3 hours later, right, 4 hours, patient feels better according to the physician. Patient now states she's not allergic to macrobid. Case discussed with the urologist, who states to start antibiotics, and we'll see in the office tomorrow. Patient and family agree. Diagnosed with renal colic, and the patient is sent home. Verbalized understanding, home, ambulatory, private car, condition improved. So that's what you got. That's what you got. And I think hopefully we've been true to that thought of not being esoteric or obvious. Like, sort of seems reasonable, right? Patient's got a stone. They put her on some antibiotics and they send her home. Now, I know you're thinking all kinds of things, right? Some of you are probably more thinking, yeah, I might have done it the same way. Some of you are thinking like, well, maybe a couple subtlety changes. And maybe some of you are even thinking like, this is absolute malpractice. If something bad happens, then this physician deserves to go down, right? So we're all sort of different in the way we think about things, right? And the way we think about our peers. So I won't tell him how I'm thinking. So what happened with this patient? So obviously we're here in the case and it's going to be a trial, so we know something good didn't happen. So patient did come back the same day, really just a few hours later. Ultramental status, now she's febrile, started on broad spectrum antibiotics. They consult urology, take her to the OR immediately for a stent. And when you think about how the data plays out, NEF2 versus stent, it's sort of whatever you can do more quickly. And I think a lot of us might go for NEF2, but hard to say what was available at the time. Patient after the stenting is extubated, begins to decline. She's re-intubated. She is hypotensive from septic shock, requires multiple vasopressors. She develops ischemia of the hands and feet. And as you sort of know how this is going, unfortunately, they have this sort of multidisciplinary team and they talk to the patient's husband and the family. And I want to just talk to you about one other thing here, because during the course of all this, and you think to yourself, well, how do lawsuits come about, right? So here's an interview, and this is actually from the actual husband. The husband relates during his deposition. And again, this is all going to be unique stuff based on this documentation, which is the actual documentation, right? But they say, what, if anything, did you say to the ICU doctor regarding the medication your wife was receiving for pain? And he answered, if they could give her anything stronger. Question, did her pain medicine ever change? I don't believe so. And then they went on further and asked about the conversation with the ICU doctor. And it sounds like I could read through the whole thing. Did you ever sign a DNR? Yes, I spoke to my kids first, told them what was going on. They both agreed we can't let her suffer like this. So your wife was removed from life support. The answer is yes. But in the end, there was a lot of conflict during the inpatient course as far as if her pain was being treated appropriately, if they were being as aggressive as they should have been, right? And then in the end, unfortunately, the patient did expire from this prolonged hospital stay, and the vasopressors and antibiotics, unfortunately, were unsuccessful with that. So we're going to ask how this plays out in our courtroom here. And this is our format for what we're going to do. I had some opening thoughts there, but we have our plaintiff team, which is going to be sitting over here, and we have our defense team that's going to be sitting over here. And we're going to start off, as trials do, with the plaintiff team, right? We're going to have the direct and the cross on our EM defense expert, Kevin Markowski, who is core faculty at Summa, right? Wherever you are, Kevin, yes. And then we have our direct and cross with our plaintiff urology expert, who is here, who is a graduate of the Ohio State University. So good to, come up to Akron and still feel like I'm in Columbus for Breeze, right? So anyway, he is a actual urologist, and he is going to be the expert for the plaintiff, and he will be on that team, right, has hired to say that this doctor could have done things better. We'll take a quick break, and then we'll come back and we'll have our defense expert, and we have Joe, who is at Boardman, and he's one of the core faculties there in emergency medicine. He's going to be the defense expert witness. And then the defense, like we said, only has one expert, but then also has Bryan, who's going to be the volunteer defendant, who's actually a resident, senior chief resident, right, at Summa. Yeah, okay. And that being said, I'm going to turn the mic over to Mike Palacci for just a sec here. And we will get things started with jury selection, which will be very quick and not nearly as long as it normally would be in a real trial.
Okay, good morning, everybody. So we're going to have a jury of 8. I want to start by introducing our jury foreman, Dr. Tom Files, up front over here. Turn around, say hi to everybody, Tom.
You could. Yeah.
So Dr. File was very gracious to join us today. Our immediate past chair of infectious disease here at Summa. He's also past president of the IDSA, and is going to spend a few hours with us this morning. And we need 7 people to join him. So we have a very diverse group here. We have emergency medicine, we have non-emergency medicine, we have nurses, APPs, medical students, residents, attendings. So I'm going to try and get as many of those groups represented as possible. So I want to start with a representative on the jury of our host institution, our host residency. So could I have a volunteer resident or faculty member from the Summa EM residency to participate on the jury? Brock Landrum's raising his hand. Come on down. So Brock Landrum is going to be one of our jury members. He's another chief resident here at Summa. Right down, any of these seats are in the front row that don't have a desk now. Okay, can I get a non-emergency medicine resident from Summa? We have, I know we have urology residents here, internal medicine residents here from Summa. Anybody, can I get a volunteer from one of those non-emergency medicine programs at Summa to serve on a jury? Come on, don't be shy. All right, come on down. We have one of our internal medicine residents that's volunteered. Great. Next, can I get a nurse from Akron City Hospital, from Summa Akron City Hospital to serve on a jury? Come on down, Bill. All right. All right. All right. Now, can I get a nurse from a hospital other than Akron City Hospital, whether it's from one of the other Summa ERs or there we go. Come on down. All right. So we've got 5. Can I get a medical student? I know we have medical students from NeoMed and from OUHCOM. Come on down. That's great. Okay. We have 2 other EM residencies that have joined us today, so I want to get a representative of both. Can I get either a resident or a faculty member from Altman in Canton? There we go. Come on down. And finally, can we fill out the jury with an EM resident or faculty member from Boardman in Youngstown? There you go. Come on down. So does that make 8? 1, 2, 3, 4, 5, 6, 7, and here comes 8. All right. Thanks to all our volunteers. Once we're done with the trial, we have a jury deliberation room set up upstairs. So we'll bring you over there while and everyone in the audience, just so you're aware, pay attention because we are going to have an audience vote as well. So while the jury is deliberating, we'll be getting some feedback from you via poll everywhere. Okay, so we have our jury selected. All rise as Judge Michael Weinstock enters the courtroom. Go.
You may be seated. Call this court into order.
Your Honor.
Actually, let's give this to, let me get that. Okay, that's right. We'll start with the opening statement from the plaintiff attorney. She'll control.
May it please the court, counsel, members of the jury. I have the distinct privilege of representing the Baker family, but I also have the distinct honor of representing the memory of Ms. Linda Baker. You're going to hear that Linda Baker was a wife, she was a mother, she was a grandmother. She had worked a long life, very hard, and was very looking forward to retirement. She was 67 years old, as was her husband. They had planned to travel, and they started to do that. They were spending their free time, as they always dreamed they could do with retirement, with their kids and their many grandkids. And unfortunately, her life was cut short at age 67. She died a tragic death in October of 2016. But as tragic as her death was, the way in which she died was even worse. Her body was ravaged with infection due to an infection that Dr. Shure failed to recognize when he had an opportunity to do so when she was in his emergency room. An infection that developed into what you'll hear called sepsis and ultimately septic shock, where her body began to shut down and the blood to her extremities was diminished to the point where she began to lose or was at risk of losing her limbs. And her family at her bedside had to do the most unthinkable thing any family member would have to be asked to do, and that's to take her off life support. And they did just that with all that family at bedside. But the real tragedy is that all of this was preventable. And all of this occurred because Dr. Shure failed to do his job. He failed to do what he's responsible to do in the emergency room as an attending physician. And whether he was too busy, whether he was just inattentive, it doesn't matter because he didn't do his job. And let's talk about the facts. October 12th of 2016, Ms. Baker was sleeping. She awoke with significant lower back pain. She had had kidney stones before, so it wasn't completely new to her, but this was a little different. It was unrelenting and it wouldn't resolve. And she tossed and turned and tried to get through the night. But her husband knew something wasn't right. They needed to get her to the hospital. So in the morning, they did the right thing. They got her to where the help should be, the emergency room. And once she got there, she came under the care of Dr. Shure. Dr. Shure was the attending that day. Dr. Shure had the responsibility to assess her, make a differential diagnosis, make a definitive diagnosis, and arrange for definitive treatment to treat an infection before sending her out that door, which he failed to do. What happened in that emergency room, it was equivalent to a whole assortment of red flags regarding an infected kidney stone that required definitive treatment that Dr. Shure missed. Let's talk about those red flags. As you would expect, she came through triage. The nurses took a history. They noted that she had had a history of cancer. So we know that somebody with cancer to some extent, maybe at increased risk for infection because she's immunocompromised to some extent. But more importantly, they noted that she had chills. Now, here's somebody that presents with a history of a kidney stone. So bad, she got out of bed, and the first thing she did in the morning was get to the emergency room, and she has chills. Ignored by Dr. Shure, not taken into account in determining whether or not this was not just a kidney stone, but an infected kidney stone. They took vital signs, but perhaps most importantly, they only took one set of vital signs on admission. And one of those vital signs was the heart rate, which was 92. And you're going to hear from the expert witnesses that a pulse rate of 92 in somebody who's suspected to have a kidney stone and potentially an infected kidney stone is actually quite concerning because it's one of several criteria you look to see whether or not maybe that infection is a more serious situation that would move on and develop into a sepsis. They never repeated the vital signs, not once during her stay. Not before she went home. She was allowed to leave without a repeat set. Her oxygen saturation was 92%, certainly borderline normal, if not outright low, never repeated. The physical examination that was done showed tenderness right at the area of the kidney, at what's called the CVA, consistent with a significant, not diagnostic, but consistent with something seriously going on with that kidney, more than a simple kidney stone. They did appropriately some lab work. Now, the lab work included a CBC that included a white blood cell count, which can be elevated in an infection. It was not, but that does not mean that infection has been ruled out. That does not mean that you don't have a problem that amounts to a brewing infection that's going to get worse over the ensuing hours. They also, very importantly, did a urinalysis. The urinalysis showed nitrates and also leukocyte esterase, consistent with an infection in the urine. Now, keep that in mind. So he was armed with information that suggested that the urine they tested was infected. And against that backdrop, he had a CT scan, the right test, good test to do, but he ignored it. He didn't put the pieces together because that CT scan should have cinched the diagnosis. It showed a 3 millimeter obstructing stone in the mid-ureter, but it also showed uteronephrosis and perinephric fluid. So this was an obstructive stone against a backdrop of urine that appeared to be infected. Game over. That patient does not go home. But what Dr. Shure did, he called a urologist on call and he arranged for close follow-up. You know what else he did? Between him and the urologist, and by the way, the urologist has given testimony in this case that denies he was given all the information that I just related to you. Because between the two of them, they decided to send her home with a prescription of macrobid. Now you're going to hear from the experts that macrobid doesn't even touch a infection that's in the kidney. A macrobid is something you would give somebody for a simple UTI. What this patient needed, what Linda Baker needed, she needed IV antibiotics. She needed to be under the care of somebody who could put in a stent or some other device that you experts will talk with you about to help drain that urine out of the kidney. Because if you can picture it, this is infected urine that's obstructed and it's just almost a cesspool gathering there, becoming more infected and then spreading throughout the body. They failed to do what they needed to do. Now, predictably, when she got home, she got worse. She became unresponsive. They brought her back to the hospital. By that point, she was febrile. By that point, she met this criteria, which you'll hear called Shure's criteria. They immediately started her on broad spectrum IV antibiotics. They immediately stented the ureter so that kidney could drain, but it was too late. Had Dr. Shure arranged for those interventions when he had Ms. Baker in his emergency room, she'd be alive today. But unfortunately, it was too late. She became hypotensive in the ensuing days. As I mentioned, her limbs began to become ischemic, and the family made that tough decision to take her off life support. Now, Dr. Shure is going to do what a lot of doctors do, and anyone does when they're being accused of something. He starts trying to place blame. You're going to hear, if he's consistent with his deposition testimony, that he'll blame the family. He'll blame the patient's husband. They were in a hurry to go home. They didn't know what allergy she had to antibiotics. He'll blame the urologist. Well, I told him, he's the one who told me what to do. I relied on him. He's blaming everybody but the person who deserves the blame. And the evidence is going to show that that blame rests on his shoulders. That's where that blame rests. If he had done his job, Ms. Baker would be alive today. And as a consequence, at the conclusion of this case, I'm going to ask that you try to right this wrong by giving a monetary award to the Baker family. Thank you for your time.
Thank you to the Plaintiff Counsel. We'll have defense give their opening statements for 10 minutes.
Good morning. My name is Carl Shedler. I'm an attorney, and my privilege today is to represent Dr. Shure, who is a defendant. You heard the opening statement from the plaintiff. This is the part of the case where we try to summarize what the evidence is. And it's important to remember that every story has more than one side. And hopefully, before you make a judgment in this case, before you make a decision as to whether or not my client is responsible, I hope you'll listen to all of the evidence that's going to be presented this morning. The evidence is going to show that Mrs. Baker came to the emergency room on the morning of Yom Kippur, October 12, 2016. She had been fasting since the night before at sundown, nothing to eat or drink. She woke up in the morning. She felt pain in her side, as she had on previous occasions, because she'd had kidney stones in the past, and all of those kidney stones had spontaneously passed through her system. But she felt pain, and she went to the emergency room. When she got there, she was seen by a nurse, and the nurse took a history. And among the things that the nurse charted in the chart was that Mrs. Baker reported to her that she did not have a fever, that she felt chilled, but that she always felt chilled and cold, making it sound like this was nothing really unusual for her. The chart also indicates that she told the nurse that she had no difficulty or pain in urinating on that particular day. And the vital signs were taken. She did not have a fever. She was not hypotensive. She had a slightly elevated heart rate, and she had a somewhat low normal oxygen saturation rate. She had a history of some cancers, but there's no reason to think, based on the evidence you will hear, that she was actually immunocompromised at the time of her visit to the emergency room in 2016. Dr. Shure saw her later in the morning, and he evaluated her and was suspected that she had a kidney stone that she had had in the past, was concerned about working her up properly, so he ordered labs and he ordered tests, including a CT scan of her kidney area, just to see what was in there. Doing those tests and doing those imaging studies required a little bit of time. So by the time those results were back, it was the afternoon. What the imaging study shows, and you'll see the evidence when we get to the case in chief, you'll see the evidence. It showed that there was a 3 millimeter stone in the mid-ureter, which is the tube between the kidney and the bladder. And if you'll hear testimony that a 3 millimeter stone is a size that normally passes spontaneously. It's only when a stone gets bigger than that it requires some intervention, or you may require some intervention to pass it. So we have a patient who has a stone. We have a patient who probably will pass the stone, who at this point is a little bit uncomfortable because it hurts, and who also has a couple of slightly abnormal findings in her urinalysis, which might suggest she has a UTI. But the other clinical symptoms you'll hear the testimony, don't suggest that. She had no dysuria, as she said, no pain, no difficulty urinating. She eager to go home. And it's understandable. It's a holiday. She'd been looking forward to it. She was getting impatient. She wanted to go home. So at some point in the afternoon, Dr. Shure offered her an IV antibiotic. And because that would take an hour, she declined that opportunity. He also spoke with the urologist and explained the case to the urologist. The urologist had every opportunity to ask all the questions that he wanted to ask. After discussing this case specifically with Dr. Shure, the urologist agreed to a plan of care that included discharging the patient to home with an oral antibiotic, macrobid, and that she would be seen the following morning at the urologist's office. The evidence or the charting at the time of discharge shows that the patient is fully cognitive, so she's totally aware of what's going on. She's interested to leave. She says she feels better. So she's clearly not confused or dizzy or in any kind of septic shock or anything like that. So the plan of care was to have her be seen by the urologist the following day. She was discharged under that plan of care, and unfortunately, something happened that night to change the outcome of this case. The question that's going to be before you is not whether anything could have happened differently that would have prevented this case ending the way it did, because obviously, if that was the standard, then every time a patient dies, the doctor would be held responsible. The question is, did Dr. Shure comply with the standard of care of a reasonably prudent emergency room physician under the same or similar circumstances? That's what the judge is going to instruct you. The law is. And the question is, what is the standard of care? Well, the standard of care you're going to hear is to do a workup of a patient like this, to get the information you need, get the urinalysis, get the blood tests, get the imaging studies, clinically interview the patient, assess the patient, take a physical, and then consult with an expert, which in this case was a urologist. And having done all those things, and in this particular set of circumstances, the evidence is going to show that Dr. Shure did in fact comply with the standard of care. It is always difficult in a case like this to try to evaluate whether the doctor did the right thing when we know, unfortunately, it ended badly. But it's your job as the jury to listen to all of the evidence and make a determination as to whether or not Dr. Shure complied with the standard of care. And at the end of the case, you're going to hear the judge instruct you on the law. And when he does, and when you retire to your room to deliberate, I hope that you'll keep in mind that the test is, did Dr. Shure meet the standard of care? At that time, I'll ask you for a verdict in favor of the defendant. Been nice to talk to you this morning. Now the evidence will be.
Thank you very much, defense counsel. So we will now call the plaintiff counsel. We'll have two witnesses. One will be the emergency medicine expert witness and then the urology expert witness, both for the defense. Now, when we do this, the first examination will be what's called a direct examination, and that will be by the plaintiff attorney to their own witness. And then the defense attorney will have the opportunity to cross-examine. So we're going to just a tiny bit shorter, 9 minutes for the direct and 9 minutes for the cross, just to catch up a little bit in time. Please proceed.
Your Honor, the plaintiff has now called Dr. Markowski to the stand. I'm going to stand over here so that you're kind of projecting towards the jury if we could. State your name, please.
Kevin Markowski.
And Dr. Markowski, can you tell the jury what area of medicine you practice?
Specialized and board certified in emergency medicine.
And how long has that been true?
I've been practicing for 26 years.
And over that course of time, Have you seen patients come into your emergency room with complaints of flank pain that have led you to the diagnosis of kidney stone?
Yes.
Have you had patients come to your emergency room where you determined that those kidney stones were obstructive?
Yes.
Have you had times when you encountered patients with kidney stones that are not only obstructive, but associated with infection?
Yes, I have.
And are you familiar with the standard of care as to what is required under those circumstances based upon your education, training, and experience?
Yes, I'm familiar with the standard of care.
Now let's talk a little bit about what the standard of care is. Can we agree that the standard of care is what a reasonable emergency room doctor would do under the same or similar circumstances?
Yes, that's correct.
Now you've reviewed certain materials in this case, have you not?
Yes, I have.
Have those materials included the emergency room records from October 12, 2016?
Yes, I did
You've
review
had a
that.
chance to review those thoroughly?
Yes, I have.
At the outset here, I'm going to ask you a very important question. Based upon your education, training, and experience, and based upon your review of those materials, do you have an opinion to a reasonable degree of medical certainty as to whether or not the care that was rendered by Dr. Shure was reasonable in keeping with the standard of care?
Yes, I have that opinion, and my opinion is that he did not keep with the standard of care in this case.
We're going to tease it out a bit, but can you briefly tell the jury the basis for your opinion?
In a patient who has an infected and obstructed kidney stone, as was in this case, the standard of care would be treating the patient with IV antibiotics, obtaining a urology consultation to decompress the obstruction, and to admit the patient. And those three things were not done in this case.
In your review of the records, did you also see that there were certain nurses' notes available to Dr. Shure?
Yes, I did review.
Did you see that those notes reflected a finding of chills?
Yes.
Can the finding or the description of chills by the patient be helpful in moving the needle either for or against a diagnosis of infection?
Commonly, a patient, especially older than age 60 or 65, will describe chills as a finding of infection and not necessarily complain of a fever.
Is that also true even in patients when their temperature is taken, it's normal?
Yes.
Did you also see that the nurses had taken some vital signs?
Yes, I did review.
The heart rate that they recorded was 92. Is that of concern in a patient who you're considering potential infection due to a kidney stone?
Yes, I would consider this patient tachycardic greater than 90 because the patient also takes a beta blocker, which can falsely lower, not falsely, but can lower the heart rate. So the rate of 92 can be considered a sign of infection or
You're
one of
referring
the,
to the fact she was on Topro?
yes,
Okay. So the fact that she's on something to lower her heart rate and she actually has a higher rate is even a more concern.
very concerning.
Is a increased heart rate or tachycardia a indication of infection, or can it be?
Yes, it can be. It's considered one of the Sears criteria or great findings of an inflammatory response.
Is there significance to the fact that the oxygen saturation was 92?
Yes, that's slightly low, could be considered abnormal in patient having an infection.
But certainly not solidly within a normal range.
Correct.
Is a patient with cancer, even albeit slight, at increased risk for infection or who had diagnosed with cancer?
Patients with cancer are at increased risk for sepsis. Patients older than age 60 are increased risk for sepsis. So those are two concerning findings in this case.
The CBC was done, which showed a normal white blood cell count. Can the white blood cell count be an indication of infection?
It can be an indication of infection, but having a white blood cell count that you called normal does not eliminate the possibility of infection.
Now, more importantly, was a urinalysis done?
Yes.
And what did the urinalysis show in terms of what may have moved the needle in favor of infection?
Well, very concerning findings were that the urinalysis showed nitrites as well as leukocyte esterase. In some studies, that's been shown to be 98% positive for signs of infection.
And then the CT scan. Can you tell the jury the significance of the fact that the CT scan not only showed a stone in the mid-ureter, as was described 3 millimeters, but what other findings suggested that despite it being small, it was obstructive?
Well, the most concerning finding to me is the fact that there was fluid in the perinephric area or the area around the kidney. What's essentially going on there, in my view of the CT scan, is that the stone is causing a blockage, literally a backup of fluid or backup of urine. That backup of urine is just simply an area where bacteria can grow. And the fact that it's showing backup swelling of the kidney and fluid around the kidney is very concerning for obstruction leading to possible infection.
Can an obstructed, infected kidney turn to a very serious life-threatening sepsis very quickly?
Yes, it can.
Is time of the essence in those circumstances to get antibiotics on board and arrange for drainage?
Time is very much of the essence. The most important things would be to treat this with IV antibiotics, so the antibiotics are within the bloodstream, and then to talk to the urologist about stopping that obstruction, either with a percutaneous nephrostomy tube or a ureteral stent.
Is macrobid an appropriate antibiotic for an upper tract infection?
Absolutely not.
Was that below the standard of care to send her home on macrobid?
Yes, it absolutely was.
Who ultimately has the responsibility to make the decision whether a patient leaves that emergency room?
The emergency department physician.
You see, first of all, have you ever heard the adage in your training or education of it's not documented, it wasn't done?
Absolutely.
And you teach that?
I commonly teach that.
Do you see any documentation anywhere to suggest that this allegation that we just heard about in opening statement, that the fact she didn't get IV antibiotics is because she didn't want it?
There wasn't any documentation in my review that the patient declined IV antibiotics.
Can you even fathom that one would not document such an important fact if that in fact was going to be their alibi in a case like this? Can you think of a reason why that wouldn't be documented if it was true?
If I was discussing with the patient their importance of care, I would discuss how important it was to give IV antibiotics in the situation of an obstructed, infected ureteral calculi.
Do you see any documentation that the details that we just reviewed, the urinalysis results, the vital signs, the CT scan findings were specifically communicated to the urologist before Ms. Baker was sent home?
I did not see that in my review of the case that was documented.
Thank you. Appreciate that.
Events with 9 minutes for the cross-examination. Mr. Shedler?
Good morning, Dr. Markowitz. My name's Carl Shedler. I represent Dr. Shure. How are you today?
Good, thank you.
Now, you read the records in this case, correct?
Yes, I did.
And you saw that Mrs. Baker came to the emergency department on October 12th, 2016, which happened to be Yom Kippur.
That was the date of her visit, yes.
Right. Do you understand that she was fasting since sundown the night before?
Yes, that was documented in the nurse's notes, I believe.
Not eating or drinking?
I did not see specifically eating and drinking, but I know she was fasting.
Okay. When she got to the emergency room, the first documented note is from the nurse, right?
Correct.
The nurse wrote that Mrs. Baker denied fever, correct?
That's correct.
The nurse wrote that she denied shortness of breath, correct?
That's correct.
The nurse reported that Mrs. Baker said she had chills, but said, quote, "I always have chills. It's been cold."
That is what's documented.
That Mrs. Baker denied pain or difficulty urinating, correct?
That's also documented.
Now, you talked a little bit ago about the heart rate, 92, which you described as tachycardic. Is that because it's over 90 beats per minute?
Yes.
Mrs. Baker was in pain, right?
The nurse's note says she denies pain or difficulty urinating.
Urinating, but she said she came in for flank pain.
That's correct.
She described it as 8 out of 10, correct?
That's in the physician notes, correct.
That's a significant level of pain, isn't it?
Yes.
Isn't it true that experiencing pain, an 8 out of 10 level of pain, a relentless 8 out of 10 level of pain, tend to cause a person's heart rate to increase.
It's one of the things that can cause the person's heart rate to increase.
Now, Dr. Shure did an exam at about 11:30 that morning, and you have the record of that.
That's correct.
And in his note, he wrote that Mrs. Baker denies fever, correct?
I don't see it in the physician note. I saw it in the nurse's note.
Okay. Well, it's closer to the end. She denies this.
Yes, I see that. That's correct.
Denies dysuria, correct?
Correct.
So that would mean that she was having no difficulty urinating. That would be your understanding of that.
Dysuria is pain with urinating. If
Right.
we denied pain with urinating.
Not having pain when she urinates. Denies any blood in her urine, correct?
That's correct.
She reported a number of allergies to the doctor, didn't she?
That's correct.
Some of those allergies included antibiotics.
Yes.
She had a history of cancer, as you said, but she was not taking any medications that would be classified as chemotherapy, was she?
That's not in the record, no.
I think you were asked and you said she might be immunocompromised. You don't know whether she was immunocompromised, do you?
She wasn't immunocompromised per the record based on receiving any chemotherapeutic agents.
Okay. The blood count, the white blood cells were normal, right?
That's correct.
And the white blood cells are kind of the first line of defense the body dispatches to an infection, isn't it?
White blood cells are part of the treatment of, are part of the body's fighting of infection. That's correct.
And do you have any reason to suspect that her white blood cell response was impeded or impaired in any way on that day?
No, I do not.
So she had a normal white count, which would indicate that at least the body was not raising a response to an infection at that point.
The white count was normal. I will disagree that there still can be infection with normal white count.
And the CT scan showed a 3 millimeter stone in the mid-ureter, right?
That's correct.
And normally a 3 millimeter stone would be one that would pass spontaneously, correct?
Not in every patient.
Not in every patient, but most of the time. More often than not.
More often than not, yes.
And in fact, she had had stones in the past, right?
That's correct.
History of that.
There is a history of previous stones.
And as far as we know, they passed on their own.
That's been reported. We also don't know what size those stones were at that time.
Now, around 3:45 in the afternoon, Dr. Shure wrote a note. It's called a reassessment note. Do you see that?
Yes.
Okay. And in that note, he talks about the imaging result of the labs and that he consulted with a neurologist, Dr. Smith.
I do not see in that reassessment note that he talks about the imaging results, the 1547 note that you're referring to.
Okay. Well, you will agree that he spoke to the urologist at that before he wrote
And
that.
that he discussed the case with the urologist.
And he wrote that the patient said she feels better. Correct?
Yes, that's correct.
And she agreed that she would go see Dr. Smith, the urologist, the following morning. Correct? She agreed to that.
It says the case was discussed with the urologist and we'll see in the office tomorrow. It doesn't say, oh, it says the patient and family agree to that. That's correct.
Right. So she understood the plan of treatment and she agreed to it. At that time, she was cognizant and coherent and had her faculties about her and certainly understood it, at least according to that note.
According to the note, she agreed with the plan of treatment. There's nothing in the note that explains what the risks would be of an infected kidney stone and treated with an antibiotic choice of macrobid.
There is a testimony from Dr. Shure in this case, that I'm sure you've been asked about, where he stated under oath that he offered Mrs. Baker the opportunity for IV antibiotics, and she declined. You familiar with that testimony?
I've heard in your opening statement that that testimony occurred.
Okay.
In my review of the medical chart, that did not occur according to the documentation.
Right. But just because it's not documented doesn't necessarily mean it didn't occur.
As I stated earlier, that's not what I would teach and not what I would do in my own practice as a board certified emergency physician.
So are you saying that ordinarily you would document something like that, but you're not disputing that it happened, or are you disputing that it happened?
I'm not disputing Dr. Shure's testimony, no.
Okay. Thank you. I have no further questions.
Thank you, Dr. Markowski, for your testimony. And we'll now allow the plaintiff to call the plaintiff urology expert. And then we'll have 10 minutes or 9 minutes for direct, 9 minutes for cross, and then we'll take a quick break before the
Your Honor, we would call Dr. Henry to the stand. Good morning.
Good morning.
Can you state your name, please, for the jury?
Fabrice Henry?
And are you a physician?
Yes.
What area of medicine do you practice?
Urology?
And how long have you been practicing urology, sir?
1 year.
Can you tell the jury a little bit about what the practice of urology involves?
The practice of urology involves the genitourinary system, so kidneys, bladder, prostate, external genitalia, adrenal glands, and ranges from oncology to urolithiasis, stones in the urinary tract, urinary tract infections, benign conditions with prostate issues.
So certainly in your training and in your professional experience, you've encountered patients who were suffering from kidney stones. Is that fair?
Every day.
And from time to time, are you consulted out of the emergency room with regards to such patients?
Very frequently.
And through your education, training, and experience, have you come to appreciate that certain instances, kidney stones can be life-threatening if there are infectious complications?
Yes.
Do you have an opinion as to whether or not those infectious complications can become life-threatening fairly quickly?
That is my opinion, yes.
You've had a chance to review the materials in this case, including the October 12th, 2016 emergency room record.
Yes.
Did you also review the records that reflect what happened later that day and the days that followed?
Yes.
First, from your review of the record, is there any doubt in your mind that the presentation that Ms. Baker described on admission to the emergency room was consistent with a kidney stone?
No.
Did she in fact have a history of kidney stones? So jumping forward for a moment, did the CT scan resolve any doubt, if there was any that existed, that she in fact had kidney stones or kidney stone?
Correct. The CT confirmed the finding of a kidney stone.
So as a urologist, did you review the record to see whether there was indications available to Dr. Shure that would suggest this wasn't just a simple kidney stone, but an infected, a kidney stone that was causing an infection?
I did, yes.
What was the significance of a heart rate of 92 as it relates to making a decision on whether or not there's signs or symptoms of an infection?
As mentioned before, it's one of the indications of a systemic inflammatory response. While it may be also a response to pain, it could be a response to infection, and we cannot say for sure which.
By the way, you saw on the record that there was a history that Ms. Baker had been fasting for religious purposes. The fact that she was fasting, does that play into your opinion at all in terms of whether she was at risk for a worsening infection?
Yes, I couldn't tell exactly with certainty how long she had been fasting from the record, but if she had been without food or drink for an extended period of time, she may have be dehydrated and less able to mount a response.
Did you look at the urinalysis?
Yes.
And what did that tell you about whether or not this was not just a simple stone, but rather an infected stone?
The presence of nitrates and leukoesterase in the urine has a high specificity for a urinary tract infection.
Can even small stones the size of 3 millimeters obstruct?
Yes.
And what is the risk to the patient if an obstructed stone, even if small, exists when you have urine that appears like this urine looked in this case?
If there is obstructed urine and the infection, the bacteria is proximal behind that obstruction in that stagnant urine. It's that urine doesn't drain, and it allows that bacteria to multiply. The analogy is like a stagnant pond. So without draining urine, it's more likely that infection gets worse to a severe standpoint.
Now, I know you're not an emergency room doctor, but as a urologist who interacts with emergency room doctors, it sounds like quite frequently, have you come to expect what a reasonable ER physician would do when faced with an obstructed stone that's against the backdrop of infection?
Yes.
What? I'm simply asking about.
Dane, please keep your questions focused to his area of expertise.
As a urologist, what would be your recommendation with regards to such a situation?
My recommendation would be IV antibiotics with inpatient observation and a timely placement of either a stent or a nephrostomy tube.
So let's move forward for a moment and talk about what happened later that day. When Ms. Baker came back to the emergency room, was she in fact septic?
Yes.
Was she in septic shock?
Yes.
From that, looking back towards the emergency room, the initial emergency room visit, do you have an opinion that in all likelihood she was infected leading to sepsis at that time?
Yes.
Do you have an opinion as to whether or not those treatments that you just mentioned, IV antibiotics and drainage of the kidney, either with a stent or a tube, whether or not that would have solved Ms. Baker's problem before she went on to become septic?
It likely would have prevented the extent of complications.
To a probability, doctor, had those steps been taken that you just outlined, would Ms. Baker be with her family today? To a probability.
Yes.
Thank you, doctor.
Thank you to the plaintiff. Defense attorney has 9 minutes for cross-examination.
Morning, Dr. Henry. How are you today?
Good. How are you?
I don't think we've met before. My name's Carl Shedler. I represent Dr. Shure. You just testified about what caused, or rather, whether or not Mrs. Baker was septic when she left the emergency room. Is that your testimony?
No.
Do you know when she went into septic shock?
Sometime after she left the emergency room.
You don't know when. In terms of clock time, you don't know when that happened to you.
No.
All right. Now, You're here today as a board certified urologist, right?
Board eligible.
Board eligible. Okay, sorry. Sorry. You would not expect an emergency room physician like Dr. Shure to have the same breadth of knowledge and experience with renal stones and urinary tract infections as a board eligible urologist, would you?
No.
And as far as the standard of care for Dr. Shure goes, you really can't speak to what the standard of care is for an emergency room physician, can you?
Correct.
In fact, the reason that Dr. Shure consulted with Dr. Smith, the urologist, is because he wanted to get the expertise of a urologist to consider what to do for his patient. Isn't that right?
Correct.
And Dr. Oliver's request for consultation with a urologist in this case, that would be consistent with your experience with emergency room physicians in the past as a urologist, correct?
Correct.
And you receive those calls with some frequency?
Correct.
And when you have a call like that, you would take the time to ask whatever questions you felt you needed to get answers to in order to give an appropriate advice to the physician who's asking for your consultation.
Correct.
And do you have any reason to think that Dr. Smith did not do that in this case?
I can't comment based on the documentation. I'm not certain.
Okay. So the answer is you're not sure exactly what was the conversation. You have no reason to think that he didn't ask any questions he wanted to ask.
Correct.
And by the same token, Dr. Shure could reasonably rely on advice that a urologist like Dr. Smith would offer to him when making a decision about how best to make a disposition in a case like Mrs. Baker's case.
Correct.
Is there anything in the record that suggests that Dr. Oliver or Dr. Smith advised Dr. Shure to admit this patient?
Objection, you're talking about the medical record or the deposition record that you certainly have read?
Objection sustained. Please clarify.
Did you see anything in the medical record to indicate that Dr. Smith recommended to Dr. Shure that he should admit this patient to the hospital?
No.
Are you aware of any other evidence of that in any record in this case?
Not in the medical record.
And in fact, Dr. Smith, the urologist, agreed that the discharge plan was to dismiss the patient on PO microban and have her come to his office the next day. Correct?
The documentation is that he agreed to start antibiotics and see in the office tomorrow. It doesn't say that they agreed to start macrobid. It just says she wasn't allergic to it.
Okay. Well, the note does indicate that that's what Dr. Shure started for this patient, correct?
Correct. That's what she was discharged home with.
So your review of the case is you don't know one way or the other whether Dr. Smith agreed to that?
I can't be certain from this note.
Okay. I have no further questions. Thank you, Dr.
Thank you to both counsels and expert witnesses for everyone wanting me. What you've heard initially is the plaintiff side of things. And I'm guessing a lot of folks here are thinking, obviously, this was an incredible case of malpractice, or maybe you're not thinking that. But if you think on the other side, you think about a patient who is hemodynamically stable, a patient who had the physician had a conversation with the urologist and arrangements to follow up that next morning. What are the chances this patient goes septic and dies so quickly from this, right? So what we're going to hear now is we're going to hear the defense side. We're going to have the defense emergency medicine expert witness, and then just make sure everyone's familiar with the terminology, is the direct by the defense attorney and then the cross-examination. We'll have 10 minutes for each. We've caught up time-wise. And then we will have the actual physician who saw the patient, who probably has some memory of that encounter that wasn't just reflected in the chart. I want to make one other quick note, and Dr. Markowski had talked about that narrative we hear a lot. If it's not documented, it wasn't done. Well, I will say, and we talked in the beginning about the fact that sometimes the actual act of documentation can make patients safer. Thinking about that medical decision-making note, and you're thinking about it, if there was a bad outcome, would I feel comfortable defending my actions to the patient's family or the department chair or to administration or to a jury, right? In that same way, when you think about the way that a that a physician sees a patient in an emergency department, right, is that we are the historian, we're not a transcriptionist, right? So clearly, every single thing that happened in that room isn't reflected in the note, or else you'd see 3 patients a day. So in the context of all that, what we're going to do here, well, the direct and cross of the defense emergency medicine expert, defense and cross of the defendant physician, closing statements, and then we're going to have the jury step into their jury box. We'll have just a little bit of opportunity to maybe a couple questions for both the defense and the plaintiff attorneys while the jury is deliberating. When they come back, they've already reached their decision. We're going to ask all of them to be the jury and first vote on 2 questions. The first question is going to be, if this physician met the standard of care, right? And then the second would be if we think that our own practice might be changed by what we've seen here today to help improve patient care. So it'd be interesting to sort of think about both those considerations. So in the context of all that, I now call the defense attorney, Mr. Shedler, to have his direct examination of his emergency medicine expert witness.
All right, we call Dr. Noga. Dr. Noga, can you please tell us your occupation?
Board certified emergency medicine physician.
And would you describe for the members of the jury the practice that you have?
I work clinically at St. Elizabeth Boardman, and I'm also the medical director at said hospital and also a core faculty member for our residency.
And how much of your professional time do you devote to clinical practice of emergency medicine?
I work about 140 to 50 hours clinically a month.
Okay. And the rest of the time you're teaching?
Teaching and administrative
Okay.
duties.
How long have you been engaged in the practice of emergency medicine?
Since 2000.
And you're board certified?
Yes.
When were you board certified?
I think 2 years after I graduated from residency, then I recerted and up for recertification in 2025.
During your practice of emergency medicine, have you ever had occasion to see patients who come into the emergency department with flank pain and suspicion of a urinary tract infection?
Yes, we do.
How often does that happen?
We see flank pain and UTIs probably on a weekly basis.
And does every patient who comes in to the emergency department with that description get admitted to the hospital?
No, sir.
How do you decide who's going to get admitted to the hospital and who's not going to get admitted to the hospital under those circumstances?
With kidney stones, if they have normal vital signs, they're not vomiting, no fever, they can take antiemetics, pain medicine at home, and those patients are generally safe to be discharged.
So I'm going to ask you about the standard of care now. And for purposes of the question, I want you to assume that the standard of care means what a physician of ordinary care, skill, and diligence would do under the same or similar circumstances, okay? You testified about how an emergency room physician might see patients like Mrs. Baker on a weekly basis. Do you have an understanding based on your experience as to what the standard of care is in that situation in an emergency department setting?
Yes, I do.
And based upon did you review materials in this case?
Yes, I reviewed the chart.
Okay. And based upon your review of those materials and based upon your training and education and experience as a board certified emergency room physician, were you able to formulate an opinion to a reasonable degree of medical probability as to whether or not Dr. Shure complied with the standard of care with regard to Norma Baker?
Yes, based on the vitals, the lab work that was done, the consultation, and provided antibiotics with close follow-up, I think he did meet the standard of care.
Okay, what about the vitals that was of interest to you that may have affected the disposition of this case?
Her vital signs initially were normal. I think there was only one set, however, but she did not have what we call SIRS. She was not positive for SIRS. She only had one SIRS criteria, which was a heart rate of 92. Typically, we're trained that tachycardia is greater than 100, not 90. So according to her vital signs and her white blood cell count, she did not meet SIRS criteria.
Okay. Please explain to the, have you completed your explanation to the members of the jury as to why you think Dr. Shure complied with the standard of care in this?
He discharged the patient on antibiotics for presumed UTI. He made a follow-up phone call with urology, discussed the case with urology, and made close follow-up so she could be seen in a timely manner.
Did he order any laboratory tests?
Yes, he ordered the appropriate labs. She had a normal CBC. She was not acidotic on her chemistries, and he did order a UA, which was concerning for possible infection.
What do you mean acidotic?
When you order a chemistry, you can look at the serum bicarbonate to see whether or not the patient's acidotic or not, which could be an indication of sepsis. And her serum bicarb, I believe, was normal.
Okay, so is that a reassuring sign?
That is correct.
Okay. What about her urinalysis? Was that significant?
The urinalysis is concerning for infection, but there's no WBCs, there's no bacteria. So it's incomplete.
Okay. And we know in this case that Dr. Shure called Dr. Smith, the urologist, right?
That's correct.
Is that something that you've done in the past as part of your practice as an emergency room physician?
That is correct.
And what would be the reason that you would call a urologist under those circumstances?
When this particular patient does have a kidney stone with a urinalysis that's concerning for infection, I would call the on-call urologist, discuss the complete case with him, and formulate a discharge plan.
Okay. And what would be the custom and practice as far as the urologist's interest in gathering information from you? I mean, how do those calls usually go?
He would normally want to know the size of the stone, where the stone was, whether or not the patient was febrile, whether or not the patient had a white count, whether or not the urine was infectious, and vital signs.
And when you've had conversations with urologists under those circumstances in your practice, does the urologist have every opportunity to ask any questions that he or she wants to ask?
Yes, they do.
And Whose decision is it with regard to disposition of a patient like Mrs. Baker from the emergency department?
It would have been the ER physicians.
And that's Dr. Shure.
That's correct.
But in making that decision as an emergency room physician, would he be reasonable and within the standard of care to rely on information he received from the specialist, in this case, the pathologist?
Yes, he would call him for recommendations, and it would be on a collaborative agreement, but ultimately it would fall on the emergency physician to relay that information and set up the disposition.
Thank you. I have no further questions on the record.
Thank you, Mr. Shetler. We'll have the now plaintiff cross-examination of our EM defense expert.
Doctor, let's see if we can come to some agreement. I assume you looked at the records that reflect what happened after Ms. Baker left the emergency room under Dr. Shure's care. Is that true?
Yes, sir.
And then in doing so, you know that just 45 minutes after she got home, she went unresponsive. Are you aware of that?
Yes, sir.
And you're aware that when she went unresponsive just 45 minutes after she left Dr. Shure's care, she was taken back in an ambulance to the emergency room, true?
Yes, I believe so.
And at that point, she was febrile and met SIRS criteria and went on to become septic and went into septic shock, didn't she?
Yes, she did.
And knowing that time sequence, sir, can we agree that in all likelihood, she was infected on her way to sepsis when she was sent home out of that emergency room the first time?
Likely she was infected, but the data didn't portend that.
Let's talk about the data, sir. First of all, is the standard of care to use it to develop a differential diagnosis? You teach that?
Yes, sir.
And would you agree that a differential diagnosis is a list of potential explanations for a constellation of signs and symptoms?
Yes, it is.
And would you agree that any responsible, reasonable emergency room doctor must make that assessment mentally?
Yes.
And would you agree that once that differential diagnosis is made, steps must be taken to rule out and treat life-threatening conditions?
Correct.
You would agree that if a life-threatening condition was on your differential diagnosis as a reasonable, responsible emergency room doctor, you would never let that patient leave that emergency room, would you?
I would not.
Okay. Now let's see if we can agree on something else. Generally speaking, let's not talk about this patient right now. Hypothetically, if you have a patient who has a stone that appears to be obstructing and other evidence of infection, is that a potentially life-threatening situation?
Potentially.
And you would never let a patient walk out if it was even potentially going to develop into a life-threatening situation. That's not, the standard of care is not to let them go out until they're treated, correct?
Correct.
Now let's talk about the data that you wanted to talk about. What we know in this case is that when that differential diagnosis should have been arrived at by Dr. Shure, he knew or should have known that the patient had chills, correct?
It's stated in the chart that she has chills, but all the time.
Let me try it again. He knew or should have known that she stated she had chills when she presented, correct?
Correct.
He knew or should have known that she had a heart rate of 92, which meets at least one of the SIRS criteria, true?
Yes, it's one.
He knew or should have known that she had a urinalysis that showed not one abnormality, but two consistent with an infection, true?
True.
He knew that she had a CT scan that showed evidence of a 3-millimeter stone, and while albeit small, was obstructing based upon the hydronephrosis, true?
True.
So he knew or should have known that she had an obstructive stone, and the urinalysis tells us there's evidence of infection in the urine, correct?
Correct.
Now, what he did was send her home, contrary to what he did was send her home with the prescription for Macrobid, correct?
That's correct.
Macrobid doesn't touch an upper tract infection, does it?
No, it does not.
That's for a simple UTI, isn't it?
That's correct.
If you wanted to treat the infected kidney that was existed by virtue of the obstruction, he needed to order IV antibiotics, broad spectrum. True?
Yes, that's true. And I think he offered that in his,
Well, I'm glad you said that. I'm glad you brought that up. Because can you show me in the record, I have it here, where he documented that he offered IV antibiotics and this Ms. Baker said no. Circle it if you have a pen.
it's not in that piece of paper.
It isn't it? Nor is there any evidence in here that he gave the detail to the urology consult that we know otherwise existed in the chart, correct?
He does say he discussed the case with the urologist.
Can we agree that a urology consult is only as good as the information they get?
That's correct.
So if he didn't give all the information, the urology consult isn't worth much. True? It is.
He would have discussed the
Admittedly.
case with the urologist. He would go over the case.
No. If he didn't give, I'm asking you to assume he didn't give all the information to the urologist, then the urologist's opinion wouldn't be all that valid. True?
That's correct.
And I assume you've read the testimony from the urologist in deposition where he says, I was not, if I had known all this information, I never would have said go home with Macrobid. Did you read that testimony?
Yes, I read all the testimony.
Ultimately, the responsibility to send a patient home safely lies with the emergency room doctor, correct?
That's correct.
And an emergency room doctor cannot blindly follow bad advice, whether it be from a urologist, a cardiologist, a surgeon, fill in the blank, correct?
Correct.
And we know based upon what happened 45 minutes later, Ms. Baker never should have gone home, correct?
Correct.
Thank you.
Thank you to our defense expert. And now we will have our defendant physician who actually saw the patient and has memory of seeing the patient. And they will first have the direct examination by the defense attorney. Then the plaintiff will do the cross-examination, 10 minutes each. Mr. Schindler?
Dr. Shure?
Good afternoon, sir.
Just by way of background, can you tell us what your occupation is?
I'm an emergency room physician.
And you specialize in emergency medicine?
I did.
And do you continue to specialize in emergency medicine?
I do, sir.
Okay. Were you on duty in the emergency department when Mrs. Baker came in on October 11th or 12th of 2016?
I was.
And who is the first member of the emergency department team that made a note that you saw in the record?
The nurse?
Is that typical?
Yes.
And did you see in the record that the patient denied chest pain or shortness of breath?
I did.
Did you see in the record that she denied having difficulty or pain on urination?
I did.
Did you see that she denied a fever?
I did.
Did you see her vital signs?
Yes.
And she did not have a fever, correct?
No, sir.
She was not hypotensive, correct?
No, she was not.
Her blood pressure was a little high, wasn't it?
It was.
Her heart rate, what was her heart rate?
92.
Okay. Was there any significance in that to you?
At the time, with as uncomfortable as she looked, there wasn't significance.
Why is that?
I thought there might be multiple reasons she could have an elevated heart rate, and I would reassess that at a later time.
Okay. Now, she described flank pain, correct?
She did.
And did she give you a history? Did she give the nurse a history?
Yes.
And what was the significant parts of the history that you recall in the record?
She had a right-sided flank pain radiating into her groin that rose her from sleep. She then had 3 episodes of emesis, and these were the symptoms that she had before with, I believe, 4 stones in the past.
Did you examine the patient yourself?
Yes, I did.
And what impression did you have of this patient after you did your first examination?
She seemed to be very uncomfortable, specifically with her right flank and right lower abdomen. Overall, did not appear ill.
Had you seen patients of with a similar set of symptoms in the past prior to Mr. Baker?
Many times.
How often do you see patients like her?
As Dr. Noga said, at least weekly.
Okay. And do all of those patients get admitted to the hospital?
No, they do not.
Okay, so what do you do as an emergency room physician to determine whether or not a patient should be admitted or not be admitted under those circumstances?
Order the appropriate lab work, and oftentimes imaging as well to get a look at the stone, and then determine how they are feeling and what the overall laboratory and remainder of the workup shows to determine disposition.
And did you do that in this case?
I did.
And do you recall the labs values that you obtained by blood or urine?
I do.
Were any of them of particular concern to you?
On the BMP, her creatinine was elevated and the GFR was low. Those were the only thing remarkable on the laboratory workup.
Okay, why would those be significant?
It tells us the kidney function of the patient.
Okay. Did she have an elevated white blood count?
No, she did not.
Is that significant?
It is in terms of assessing service criteria.
Why?
So to meet service criteria, you need to meet 2 of the 4 criteria before you start really delving into the idea of sepsis. White blood cell count, heart rate. You look at their respiratory rate and temperature. Sorry, a little nervous down here.
Have you ever done this before? Ever testified before?
No,
Okay, so you're a little bit uneasy.
a little bit.
Well, the respiratory rate was 18. Is that a normal rate?
It is.
And her temperature was 98.5. Is that normal?
It's normal.
Okay. Her O2 sats were 92% on room air. Is that normal?
It's a very low end of normal, but it is normal.
Okay. So you also said you would order an imaging study. Did you do that in this case?
I did. I ordered a CT scan.
Okay, and why a CT scan compared to another imaging test?
Not all stones are able to be visualized on a regular radiograph, so CT imaging without contrast is standard of care.
Okay. And when you saw the results of that imaging study, what did you pick up from that?
I saw a 3 millimeter obstructing stone concerning for hydronephrosis and also some perinephric fluid, which could be consistent with pyelonephritis.
Okay, and so not everyone, at least in this country, is up to speed on the metric system. So could you describe what 3 millimeters is compared to the diameter of a pencil, say?
Much smaller than the diameter of a pencil. I guess the easiest way would be to say a centimeter is approximately 2.5 or 1/3 the size of a inch. So it's basically 1/3 the size of that.
Okay.
Very small.
When you see a 3 mm stone in the ureter, do you have any expectation as to whether it's going to pass or not pass on its own?
Stones that are 5 millimeters or less in size have a greater than 90% chance of passing on their own. So I expect it to pass.
She had a history of stones in the past, right?
4, I believe.
Okay. And your understanding was they all passed on their own?
She did have a lithotripsy once. The other 3 passed on their own, and she never required a stent or neph tube.
Okay. Now, at about 3:47 in the afternoon, you wrote a note that's called reassessment. Seen that?
Yes.
What does that mean, reassessment?
It's when I go and reevaluate the patient,
Okay.
repeat a physical, or just see how they're feeling.
Okay. And what's the purpose of doing that?
I want to ensure that this patient wasn't getting sicker and that the medications I gave, including morphine and antiemetic Zofran, were helping.
And based on your observations, were they?
Yeah, she had complete symptom improvement.
Okay. Did she tell you that?
Yes, she did.
She seemed to be able to communicate with you clearly.
Yes, she was able to communicate clearly.
At the time of your reassessment, had you spoken with any other physicians about Mrs. Baker's case?
I had paged the urologist. I hadn't spoken with them yet, though.
Okay. So, why did you seek out a urologist?
Due to the CT findings and basically wanted to ensure that I could get close follow-up for the patient.
And were you interested in hearing what the urologist's opinion of what was going on with this patient? Were you interested in hearing that?
Absolutely.
Why?
I was asking for an expert's opinion, and with all the information that I provided them, I wanted to ensure that I was doing the best I could for the patient.
Do you feel there was any information about this patient that you withheld from the urologist?
No, I did not.
Did the urologist have every opportunity to ask questions of you about this patient?
Absolutely. I actually went back to the patient's room and clarified some allergies, and the urologist was on hold. So there was a significant amount of time to ask questions.
Okay. And did you discuss with the urologist the possibility of doing IV antibiotics?
I did.
Okay. And why didn't you do that?
The patient was in a hurry to get home and did not want to wait the extra hour to get antibiotics. I threw an IV.
Do you have that discussion with her?
I did have that discussion with her.
What's your best recollection of how that discussion went?
I let her know that the IV antibiotic ceftriaxone would better reach the renal parenchyma, and also that she had had allergies to Ceftin before, so I wanted to ensure that she would not develop a reaction and I could monitor that in the hospital.
Okay. And having given her that information, what was her decision?
She really wanted to go home.
Okay. And why would she have to wait an extra hour to go home with that?
It's just the length of time that the antibiotics go over.
Okay. So what was your ultimate decision with regard to this particular case?
After discussing the antibiotics with the urologist and finding that she was not allergic to macrobid Although it wasn't as broad spectrum of coverage, we did want to put her on an antibiotic we knew to be safe and to discharge her home with follow-up the next day.
And when she left the emergency department, what was her mental status?
She had no focal deficits that I could see.
Focal deficits.
Just her overall mental status. I didn't ask alert and oriented type questions, but she didn't look like she was altered whatsoever. She was seemed to be fully functioning mentally wise.
Did she agree to the plan of treatment that you had come up with?
She did.
Did she have any questions?
Not that I recall.
And were you in the emergency department when she returned?
I was not.
Okay. And when was the end of your shift that day, do you know?
Right before she came back.
Okay. I'd like to ask you about standard of care. Based upon your training experience, do you have an understanding of what the standard of care of reasonably prudent and diligent physician in the emergency department would do under the same or similar circumstances in this case? Do you have an understanding?
Yes.
And based upon your understanding of the case, what you did, what you charted, who you talked to, who you examined, do you have an opinion to a reasonable degree of medical probability as to whether or not you complied with the standard of care of a reasonably prudent physician in this case?
I did.
I have no further questions. Thank you.
Morning.
Morning, sir.
Doctor, do you think physicians can make mistakes?
Yes,
You make mistakes?
I have made mistakes.
You think when a physician makes a mistake, he or she should be held accountable? Cross-examination.
Oh, good point.
Yes, I believe they should be held accountable.
Do you think you should be held accountable when you make a mistake?
Absolutely.
You made a mistake here, didn't you, sir?
The patient's outcome is very unfortunate and I feel terrible, but I don't believe I made a mistake.
I thought I heard you say that the CT scan findings cinched the diagnosis for you of pyelonephritis.
It was concerning for pyelonephritis.
And pyelonephritis, by definition, is inflammation typically due to a bacterial infection. That's the medical definition if you look it up in a medical dictionary, correct?
Quite possibly, yes.
Well, wait, you're the doctor. Isn't that what pyelonephritis is?
That is what pyelonephritis is.
So while Ms. Baker was in your emergency room, you had concern that she had pyelonephritis, i.e. inflammation due to a bacterial infection in her kidney, correct?
I did.
And yet you sent her home on a prescription for macrobid, which, well, first, is that what you did?
After determining she had decision-making capacity, that is what I did.
So you sent her home on an inferior antibiotic that you knew wouldn't touch pyelonephritis.
If she did have pyelonephritis, it would have less penetration.
You would not give macrobid for pyelonephritis, true?
I would like to give a broader spectrum antibiotic.
And the reason you want to give a broader spectrum antibiotic is because that's the appropriate treatment for pyelonephritis, right?
Yes.
And I assume that you came up with this story about offering her an IV for which she refused because you know that was the standard of care and you needed to have an excuse as to why you didn't do it, right?
That's not true at all.
Well, if it was true, something so important would be found in your notes, sir.
I agree that I should have written a more thorough note, but I did have those conversations.
Can there be anything more important in your practice in terms of documentation than documenting that a patient refused life-saving therapy? Anything? Can you think of anything more important to document?
Not right now.
And it's nowhere found in your note. True?
This is true.
And your other defense, I take it, is I just followed orders. The urologist told me to do it. Is that your other defense here?
My defense is that I reached out to an expert and together we came up with a plan. Yes.
A urologist can only give advice. This was over the phone, right?
Yes.
A urologist or any consultant can only give advice if they're provided all the pertinent information. True?
It's true.
And you know depositions have been taken in this case. True?
Yes.
And you know that urologist denies that you gave him all the information. You know that to be.
That was in the deposition.
And again, you didn't document that you gave all the information to the urologist either, did you?
It was not documented, no.
So we can agree that Ms. Baker left your emergency room, left your care with a condition that you knew was potentially life-threatening, i.e. pyelonephritis, on an inferior antibiotic, correct?
Miss Baker left the emergency room with the differential still possibly being pyelonephritis. Yes.
She left your emergency room with a life-threatening illness that remained on your differential that had yet to be adequately treated, true?
Yes.
And not surprisingly, 45 minutes later, it came to fruition and manifested because she returned to your emergency room while you were probably on your way home to see your family in septic shock. Isn't that how it ended?
That's how it ended, but it was very surprising how fast that progressed.
I have nothing further.
Thank you to the witness, defendant, and appreciate your time doing this. We'll have now 10 minutes each for closing statements. The plaintiff will go first, and then the defense will follow. So 10 minutes each. Start with the plaintiff.
At this point in a trial, and at many points in a trial, I'm reminded how important the word truth is. This word is thrown around a lot in society, but when you walk into a courtroom, the word truth becomes all important. And when we pick a jury, like we did earlier today, that process is called voir dire. The literal interpretation of voir dire is to speak the truth. Each witness, before they take the stand, raise their hand high and swear to tell the truth, the whole truth, and nothing but the truth. And what we've learned is that the truth is resilient. You can throw a lot at it. You can throw smoke at it. You can run from it. You can try to come up with alibis and excuses, but the truth always endures. And the truth in this case is that Dr. Shure breached the standard of care and tragically caused the death of Ms. Baker. Now, this case had a first for many, and that is you all listened a moment ago and you heard not from my experts, but you heard from the very expert called on behalf of the plaintiffs that Ms. Baker never should have been sent home. You heard it right at the end, that the standard of care required that she be admitted, she be placed on broad spectrum antibiotics and admitted to have that kidney drain. And we know if that had happened, she'd be alive today. Now, why did that happen? Why did we hear that? It's unusual to have a witness on the other side make such a broad concession, such an important concession. You know why? Because it's the truth. And ultimately, that's where the analysis should begin and end in a courtroom. Now, why do we know it's true? You've been very attentive and we appreciate your time. And I can't tell you how important it is to the Baker family to see the dedication and attention that you've given throughout this morning, listening to the evidence. But quickly to review, there's now no question, based upon the admissions we heard from the stand, that Ms. Baker had an obstructing stone, regardless of the fact it was only 3 millimeters, that there was evidence of infection, and we know that the definitive treatment is not going home with macrobid, and we know that the definitive treatment of IV antibiotics and drainage wasn't done. That should begin and end your analysis in this case. And we know that the excuses that were thrown out aren't valid. That Ms. Baker, and the audacity to blame Ms. Baker, that she refused a life-saving therapy because it would have taken another hour. Absurd. The audacity to blame the urologist when there was only one person that could get it right. Only one person. And he simply didn't do his job that day. Ms. Baker's death and the way she died was a terrible tragedy. But I'm going to tell you, that tragedy will only be compounded if there's not accountability. There has to be accountability for that mistake that so tragically caused her death. And you can't bring her back, but you can help make that wrong right by fairly compensating the Baker family. Now, you're all going to go home when this is over to your homes and your family. I'm going to go to mine. Mr. Baker's going to go home to an empty house. He's going to spend the rest of his years by himself. And that never should have happened. It was avoidable. And I would ask that you make that wrong right. Thank you.
That was an impassioned closing argument from the plaintiff. And a lot of times as a defense attorney in these kinds of cases, I find that the plaintiffs tend to appeal to your less rational side. But I'm here to point out a lot of things that I think are facts that I think should be kept in mind in this case. When Mrs. Baker came to the emergency department, she said, "I have no difficulty urinating. It's not painful." She came in with flank pain that she had had several times in the past related to kidney stones that she had passed. When Dr. Shure did the workup, he found a small size stone in the ureter. And yes, that does obstruct the flow of urine in the ureter. But we know that she was able to pee because she said she was able to pee. So was it an obstruction? Now, when Dr. Shure saw this patient in the afternoon before she went home, she clearly understood what he was talking about. He explained it to her. He testified that he explained it to her. He testified that he told her what the risks were. But she decided she wanted to go home. And patients have the right to do that. Sometimes patients don't always do what you want them to. Does that mean that you're guilty of malpractice? No, you try to do the best you can with the circumstances that you have in the case that's in front of you. And here, the best that Dr. Shure could do was to get a patient to take an antibiotic that she wasn't allergic to. It was an antibiotic that definitely was effective against urinary tract infections, perhaps not a kidney infection. But she was being handed off to a urologist who agreed to see her the following day. She was feeling better. She showed no signs of septic state of mind. She wasn't in septic shock when she left the hospital. Something must have happened. I'm not sure it was 45 minutes later, but it was shortly after that. Something happened and her condition changed. Dr. Shure shouldn't be judged by failing to diagnose and treat this septic shock episode that came up after this patient left the emergency department. He should be judged by what her condition and status was when she was in the emergency department. And what was before him was a patient who had no fever, had a mildly 92 or 92 heart rate, slightly over the threshold. She was in pain, which could very well explain why her heart rate was higher. She was not acidotic. She had no fever. So her condition at the time would not portend this kind of result. So to blame Dr. Shure because he was not able to predict the future is just plain unfair. He did what the standard of care required. He worked this patient up. He evaluated the data, and he made a decision based on that data that was reasonable at the time he made it. And you have to be able to put your hand on the page and not look at the rest of the story, because it's unfair to Dr. Shure to say, well, he should have seen what happened coming when he really had no way of knowing that this was going to happen. So when you apply the law in this case, which the judge is going to explain to you, the law is the plaintiff must prove that there was a breach in the standard of care. And I don't believe they've proved it, but that's for you to decide. That's for you to decide based on the evidence you heard, not on the arguments of the lawyers, not on what you think would be a nice thing to do. You have to base your decision on what the evidence was and what this physician defendant did based on the case that was in front of him on that day. And I think when you do, you'll see that he complied with the standard of care. And that is the end of your inquiry. Because at that point, there's nothing further to decide. The case should be ruled in favor of the defendant. So I'm going to ask you, when you retire, to deliberate, to vote and decide in favor of Dr. Shure in this case. Thank you.
Thank you. And that completes the phase of the trial where we present arguments. I'd like to ask the bailiff, Mike Palacci, to please take the 8-person jury to their deliberation room. We have a jury foreman, Tom File, who interestingly was the past president of the Infectious Disease Society of America, IDSA, and this is truly a jury of our peers of healthcare professionals. So if you please retire, and then I'm going to actually grab this mic, and while you are all walking out, the instructions. So right. So the instruction to the jury is that this is not excellence of care, not how you would take care of the patient, but this is if this method standard. In other words, what a reasonable, similarly trained, and your physician in a similar circumstance would do in the situation. Anything that further would, like Carl and Bill, would need to be given as far as instructions to the jury when they leave?
And if you do find a breach in the standard of care, was that breach a proximate cause of injury or death?
Right, I'm glad you mentioned that. We really didn't talk about the foundation, but you could make. You've heard of it, but yeah. So we really two things you deciding whether it breached the standard of care, and if it did, whether that care resulted in the injury suffered by that. But two things. Okay. Yes.
To what extent do we need to decide that? Based on reasonable health or no?
51%, just, we need to tip the scales like that.
51%, yeah, okay. Right, so what I'm gonna ask all of us to do while they are deliberating, and we'll hear what they decide without all of us. I guess the first thing to think about all of us is, who feels that in the future, when you speak with a consultant, you will have a little bit more extensive documentation of that, right? Seems like, doesn't it, right? That's one of the most frequently asked questions is how you document conversations. And what you want to avoid is what you talked about before, that the consultant later said, oh, if I had only known that, of course I'm going to investigate. Saying that the conversation that you had with the consultant was, yep, it sounds like they have GTI. So the next thought is, yeah, say you had spoken with the consultant and they said, we agree the patient has a UTI and we'll see the patient tomorrow morning, arrange for a stent. Now, it still makes me nervous, right? But at least you would have had a little bit more things to argue. Let me ask you, what do you wish when you were standing up here and like, obviously, like literally, I would have been like having a panic attack answering those questions that you were being asked from Bill. If say that you were this actual physician and you saw this patient, what do you wish you had reflected in the documentation that would have more firmly supported the argument that you have that you met the standard of care?
Yeah, I would document both any conversations that I had with the patient and the urologist. I think that if I would have documented a very thorough discussion about risks with the patient, I think that would make it more of a clear cut that I did everything possible for the patient.
So it's interesting that sort of thought, and I'm in the midst of writing this article called SDM or CYA. And what I found that happens oftentimes with shared decision making, and we all had this conversation, so I wanted to sort of address that elephant in the room a little bit, is that like we give the patient a choice, but it has to be a choice between two reasonable alternatives. And most importantly, it has to be with our guidance as the healer, as the clinician that's seeing that patient, right? So say the patient does decide to leave, I think an argument could have been, well, then why didn't you have them sign a form against medical advice if they decided they didn't want to stay? To me, it feels like if you only had one choice to write a medical decision-making note or to sign the form, you'd always go for the MDM note. But I mean, like literally, like how many times are we signing AMA forms? Like hopefully it's not that often, once a month or once a week, whatever, once a year. I mean, so literally if it's like taking up so much time signing that form, probably need to reassess practice just a little bit, right? So to me, it feels like if the patient says they're not going to stay, they refuse to stay, they understand the risks, and maybe even with that reassessment, you document the fact that they're alert and orient times 3 or whatever, have that decision-making capacity, which they think they probably did. That's how you remembered it. But, you know, we've had a bunch of cases that I've gone through where a patient does have a bad outcome soon after leaving the ED, and you figure that person probably didn't really have that complete medical decision-making capacity. I know I'm asking all the questions, so I'm gonna ask like one or two more, then like literally we have this opportunity to speak with these two great attorneys. So what else you would ask? Bill, I wanted to just sort of also bring this home. You know, Bill is actually a defense attorney. And literally, he's having way too much fun up here as a plaintiff attorney. I mean, like I sort of get that. Like that's what you always wish you could do, right? You know,
I'm a defense attorney until today, and then
yeah, right, exactly, right. So let me ask you then to put that other hat on. If you were the defense attorney, how would you, in defending this position, how would you argue? Would you even accept this as a defense case, or would you say, man, we just need to settle?
you always accept it, and then you decide, what you do with it. And the question always becomes whether or not it's a case that has so much risk in terms of trying to convince a jury that it deserves some consideration to resolve in advance. And quite frankly, this is a case that probably highlights as well as any the importance of documentation. And you can do everything right. And if you have poor documentation, the case becomes a real challenge to defend. And so this would be a completely different case if that note clearly documented, and I agree with you that it almost rises because what was declined was life-saving therapy, potentially. It almost rises to an AMA situation, but even without going that far, certainly a note that indicates that conversation was had. Of course, the other problem with these facts is that the urologist, based upon the deposition testimony, mock deposition testimony, he wasn't buying into it that he knew all those facts, or if he had, he would not have agreed to send somebody home on macrobid. And so any way you cut it, it's going to be a tough set of facts to defend.
And you saw what Bill did very cleverly. He asked a lot of questions that there was only one answer to. And, you know, as the defense expert and defendant, you know, I know that you guys were up there and like, want to answer a different way, but you can only answer that one way. And I've seen that so many times in deposition and trial testimony. They ask the question and there's only one way that it could be answered. And you want to say, but I have to tell you about the context or about the specific patient or whatever. And you can't, because that's the way that in a really clever way is asked. So Carl, let me ask one other question then if other folks have thoughts here. If you had this case as the defense attorney, would you settle this case or would you take this case to trial?
Settle.
Short answer. Yeah. So how about this? How about if this was all of us and this was our case, who, as the recommendation from your attorney, just for example, would say, I'm going to settle this case? And who would like to take this case to a trial? And who is like so happy this wasn't our case, right? Yeah, absolutely. And so when you think about it, it's like a really curious thing that we're doing here, right? Like you wouldn't imagine like the dog trainer, like 4 years later gets sued because like the dog bit someone at the park, or that like the high school English teacher is sued because your kid didn't get into great college. But yet for all of us, right, that's always that possibility. I will say, though, on a very positive note, that it's not the volume of the chart that's important. It's really the quality of what we're writing. So War and Peace is not as important. The more important thing is to really reflect the question that the patient's presentation had. So someone might come with chest pain. Their question is, am I having a heart attack? But the question the presentation is asking, am I having ACS, PE, dissection, other things, right? And we need to, in our documentation, answer that. And then one other little secret thing behind that, and this is what I think is one of the most important things, is to make sure that the patient understands when there is some diagnostic uncertainty when they leave. And I've seen so many times when patients, now this situation with our case was 45 minutes later or whatever, short time after, right? But sometimes the next day or 2 days later, 3 days later, and they ask then the surviving spouse or the patient, if they did survive, right, why didn't you go back to the ER? And literally the answer every time is, I was already there. They did all the tests. They told me everything was fine. And the very first case in the Bounce Backs book, medical legal book, is a patient who was in the ER with chest pain. She got sent home. She collapsed that night. And when the husband called the paramedics, the documentation from the dispatch, she's choking on a piece of chicken. And when she got there, that's the same thing he told the paramedics. She was in the ER that morning for chest pain. And he thought, there's no way it could be a heart attack. She's already been to the ER. They've ruled everything out. And there's a lot of other things to that case. And they didn't do troponins, and her seemed like more like acute bronchitis and all that kind of stuff. So there are arguments on both sides of that too. But the point is just that, if there is some diagnostic uncertainty, we want to make sure that the patient understands it when they leave. So then they would come back, and maybe that's that 1 or 2% acceptable in the straight with chest pain. So I've talked for so long here. Let me ask you one other question before the jury returns, before you hear what they have to say. If we were all the jury, who would say that the physician met the standard of care? Oh. Oh, okay. All right. Okay, perfect. That sounds good. So the question is, as a nurse, how often does their documentation get brought in to criticize the documentation of the physician?
I'll take a stab at it. Actually, there's been a recent Ohio Supreme Court case that came down that suggests that by most people's interpretation, that if you're going to claim that a nurse committed malpractice in addition to a doctor, you now need to name them individually or get the institution to agree that they're not going to raise that defense. So just as a practical matter, we are seeing way more than we've ever seen before, that not just physicians are being named individually, but nurses are being named in lawsuits at a rate we've never seen. It's all because of this lawsuit. So when a nurse is an actual defendant in the case, then the likelihood of that nurse being deposed actually increases. And the plaintiff's lawyer has one goal, and that's to try to pit, if they can, one defendant against the other. So it happens quite frequently that they'll try to, and that happens even if the nurse isn't named, but just called as a witness to suggest that perhaps they remember something being told to a doctor that's not documented, or vice versa. So it's happening more often, unfortunately.
To expand on that a tiny little bit is that we talked about how important the documentation is, but just because we document something, I mean, if that thing turns out that it wasn't really true, well, there are other people there. There's family members, there's nurses, there's techs, there's maybe residents, there's other people there that can be brought in later. And so say you document, I don't know, not worst headache of life. I don't love that myself, but that being said, you document something like that, and the patient, like another case that I have too, who came in by ambulance at the age of 15, right? For the first time she's ever had a headache, of course it was the worst headache of life. So just because you document something, you want to make sure that that's actually, that's accurate and that it's true. I mean, that's super important to do.
There's
So-
another phenomena that's developed here in recent years, and that is patients are tape recording everything. Everyone's got their iPhone on them, and it doesn't have to be obvious. They can just click record. And more we're seeing cases where now we're specifically making sure we ask for those sort of things, because we don't want to find out afterwards that the whole thing's been recorded. But, I would assume you're being recorded, because if it's not the patient, it's a patient's family. Many times they say, I was only recording it so I could share it with the rest of my family when, they got here or when I got home. But more and more, that's a piece of evidence that's being considered once we get into discovery and ultimately get into a courtroom.
Responding to the question about nurses, let me just say, I've mostly defended the hospital at Ohio State. So a lot of cases that dealt with nurses. And one of the consistent situations that I would see is when there's an order for pain meds, PRN. One of the things I think that's really important is to document why you're giving pain meds, even if it's PRN. Is there some aspect of the patient's condition, either what they complain about, maybe their heart rate, something they're doing that justifies why you're giving an additional pain med, even though the order is for PRN, and you feel like you can sort of give them when you think they need it. What the nightmare case that happens is that the patient just sort of overdosed. And if you haven't explained why you gave meds when you gave them, then you're going to have a hard time with that case. And it's just a documentation issue. But, if I have a son who's a nurse, and I've sort of said, yeah, you need to be pretty careful about how you document, especially pain meds.
We have a MRAP case that was about maybe 4 years ago or so, but a patient who had morbid obesity and sleep apnea, who was on benzos, and then he got his narcotic pain medicine. Of course, you wanted to treat the pain, but wasn't monitored on pulse ox, and that patient ended up dying in the hallway of the ER. And there was obviously implications to that. So certainly, one dose of Dilaudid or fentanyl or whatever is not going to harm anybody, right? But when you put all these things together, sometimes they can compound, each other. And, we always are, again, trying to do that balance with managing pain and stuff too. Other questions? Thoughts? Yeah.
We do these medical malpractice cases that would be something trials and strategy.
So the question is how often that the medical malpractice cases actually go to trial, right? Or, bench trial. Okay. You want to start that one?
I don't think it's very often that they become bench trials, because both sides have to agree. And I think the jury's right. But yeah, it doesn't happen very often. On the other hand, when I was defending the hospital at Ohio State, just because of the way the law works, there is no jury case against the state of Ohio. So those cases were all tried by judges. And actually, we found that the judges were, tended to rule in favor of the plaintiff more often than juries supposedly do. So I think sometimes it just depends on the case. Personally, I think that there's cases where I would have preferred to have a jury as opposed to having a judge. So.
Okay, we have our jury has reached a verdict. Have the jury please return to the courtroom? Can we have the jury? I'll have you do me a favor. If you could just stand up here for just half a second here, I'm going to have you introduce yourselves. If you're going to stand facing that way. I know there's more than you bargained for, wasn't it? Yeah. So just if I can, you are.
Yeah, Chief Residence at Summa. Hi, I'm Alex Malik. I'm one of the third-year IM chiefs.
Jacqueline Mentz. I'm a registered nurse in the float pool at the emergency department with Summa.
Hi, I'm Flora. I'm a third-year medical student at Neomed.
Bill Roller, second-year trauma float, Akron City ER.
I'm Thais. I'm one of the ER residents, third year as well at Boardman. I guess I'm a chief too.
Hello, I'm Tyler Bender. I'm one of the third-year residents at Altman Hospital, also chief resident.
Tom Fowle from ID Students here at Summa.
All right. And Tom, you are the jury foreman?
Hold on.
Oh, hold on.
We want to take an audience vote first.
All right.
right?
Okay. All right. We have reached a verdict. It's already written down.
All right. If the jury would like to sit back down, we have a series of questions for the audience. This is for both the audience here at Summa and the audience online. So there's a series of questions. There's 6 total. This is the first one. First question is, did Dr. Shure meet the standard of care in his treatment of Mrs. Baker? We're texting one of those 2 numerical codes for yes or no. We're texting that to 22333, and we'll be able to see the vote tally live. So go ahead and text in your vote now.
This is great.
And I'm going to vote too. What do you think of that? Okay, we're going to advance to the next question. I guess it's the first 25 people that get it. Well, I've used this app many times and there's never been a max, so that must be a change. Apologies for that. If Dr. Shure did not meet the standard of care, so let's leave this to the people that voted that he did not, was that breach of the standard the proximate cause of harm to Mrs. Baker? Jury, you don't get the double dip. You've already got it. Okay. Looks like the answer to that is yes. Okay, we can advance to the next question. Is the summary of those 2. Based on your answers to the previous 2 questions, how do you rule in the issue of Baker versus Shure? Now, I will give you a little editorial comment here, and the attorneys can tell me if my numbers are incorrect. But what I've been told is that in the state of Ohio, of the cases that go to trial, approximately 75 to 80% of them are found for the defendant. Is that
That's a fair estimate.
fair estimate? You agree with that, Carl? Is it? Yeah. So this is, it's not the most common verdict, but this is the verdict we've come to in this room. Okay, next. Will your practice change based on the information presented today? That would include documentation or really any aspect of care. Well, that's pretty definitive, huh? Okay, if you could, and scroll down as well, Alexa, because there's some more down there. Just kind of go back and forth a couple times. Okay, we're done pestering the audience.
Okay.
Dr. Weinstock,
All right.
you have a verdict from Dr. Fowler.
I'm gonna have you get up as the jury foreman and read your verdict.
Sir, Judge Weinstein. Well, after very significant deliberation under the first question was a breach of standard of care, the jury found 6 yes, 2 no. And then the second question, did the breach lead to harm in the ultimate outcome? The jury, after significant deliberation, said 2 yes, 6 no. Okay, as far as the first question on a breach of standard of care, I thought what influenced us most was actually testimony from the defense, whereby, first of all, the witness for the defense actually said under oath that he felt that the patient should not have been discharged, number one. And then also when Dr. Shure actually, when asked how to interpret the CAT scan, said that the fluid, the paranephric fluid suggested pyelonephritis. And so that suggested that the antibiotics therefore were probably inappropriate. So that's why the majority, at least 6 out of the 8, said, well, there's standard of care was breached. But then when we asked about did that lead to the outcome, well, we can't identify definitively that even if given an oral antibiotic sending home that would have been appropriate would have had changed the outcome at all. And there was sympathy by the jurors that, although not documented, Dr. Shure said that he discussed with the patient what the appropriate antibiotic should be, and that we all agreed that what he recommended was appropriate to get IV ceftriaxone. And I might add, sort of editorially, I think this case illustrates significantly the harm of when patients' allergies are put on a chart that we don't truly document that they're allergies. Because I guarantee you, 90% of the patients that that had this up here are not truly allergic to these drugs. Most of them are just adverse events that are put on the chart as allergy. And then what happens? Then you start considering, well, less effective antibiotics, more toxic antibiotics, etc. So it's really important to truly clarify when patients say that on a chart. But that's nothing to do with this case in that respect.
So thank you guys so much.